Well, let's switch gears a little bit. We talked about the diagnosis and the early therapy. Let's now talk about the patient that clearly has disease and is no longer surgically curable. When do you begin to think about initiating therapy in medullary thyroid cancer patients that are no longer curable? Marcia?
Well, if we look at, so there are a couple of interesting studies that we'll just take people who have disease from the beginning. They're the people who have no metastatic disease or local recurrence or metastatic disease at the time of diagnosis. And I like the studies that have shown this because I think they're very, very important to our understanding of the natural history of the disease. When you look at these curves, especially for metastatic disease, you'll see that approximately 50 to 60% of people will actually succumb to their disease and die in the first 3 years. So there's clearly half of the patients who are very, very likely to rapidly progress. In other words, to be, probably need the therapies right away, and it will be important. But interestingly, there's also 40% of patients that will be alive in 10 years. It's like a really dichotomous group. And so in a way, we go right back to the same paradigm we have with papillary. You have to know that they're progressing because, again, they could have been sitting with those nodules in their lungs for 6 years, and I don't know where they are. Are they going to be growing quickly, or are they going to be 10 years from now? I had a woman who had her disease for 21 years and didn't really have trouble with it growing until literally the last 3 years of that when we started therapy. And it would have been a terrible thing for me to give her toxicity for 17 years unnecessarily. So I think we have to understand there really are two types, and we need to figure that out. And the best way is really by doing the scans. And then the other thing we can use is calcitonin doubling time, or even CEA doubling time. There's very good prognostic information that says that if the CEA or calcitonin double in less than half a year, they're very high risk for progression and death, actually overall survival. Whereas if they are having a doubling time in over 2 years, they are the ones that will probably die of something else. And so those two things, the cross-sectional imaging, looking for progression, and the doubling time are two things that we use to decide, is this the person we treat?
Well, you mentioned clinical trials in medullary thyroid cancer, and in fact, we do have phase 3 data in this disease. For instance, the zeta-vendetinib trial was a phase 3 study in refractory, incurable medullary thyroid cancer that demonstrated efficacy in these patients with a median progression-free survival of 19.3 months in the placebo group versus a median progression-free survival of 30.5 months for vendetinib. With those data in mind, Frank, when do you use vendetinib in patients with medullary thyroid cancer?
Yeah, this is an interesting question because we now have two approved agents. We have vendetinib and cabozantinib, and we don't have sequencing data in this particular tumor type. So I have a tendency to use cabozantinib first in a lot of patients who have bulky disease, and especially those patients who have bone involvement. I think that it perhaps works a little bit better. I mean, this is my anecdotal experience. And then once they maximize the benefit with cabozantinib, I will change to vendetinib. I do think the side effect profile is better overall with vendetinib. So I think that a patient is not going to tolerate cabozantinib, then I will start with vendetinib up front.
Manisha, we talked about toxicities a little bit with the TKIs. How do you manage toxicities on vendetinib and specifically the dermatological toxicities that we see with this agent?
So vendetinib in particular has a unique skin rash that are more like acneiform rash that happens on their upper chest, back, and maybe on face. And so for that, we basically do clindamycin gel. Some patients don't really want anything. They are like, okay, it doesn't bother us. We just move on. So it's not a serious toxicity, but it's something. The other thing is that we always ask them to use the sunscreen to avoid the photosensitivity. And then they could also have a regular drug rash where basically, they're itchy, erythematous papular macular rash where you basically just give antihistaminic. So it's rarely that you see those diffuse Steven-Johnson type of rash that we've seen with, for example, sorafenib, but we have not observed that with vendetinib or cabozantinib.
So vandetanib is a little bit unique in its toxicity profile
Yes.
because of its ability to inhibit epidermal growth factor receptor, and we have to be aware of the
Yes,
different
yes.
skin toxicities. Thanks, Manisha. Frank, you mentioned the